Hi, everybody. Welcome back to another chapter of Menopause Supports here on the National Menopause Summit YouTube channel. And I am delighted this evening to be chatting with the wonderful Dr. Sumi Dunne. And Sumi is a GP in Portarlington in County Laois, and she's also a lecturer in GP practice at the Royal College of Surgeons in Ireland. And you may also, and I'm sure, recognise Sumi as the GP expert on Operation Transformation on RT. She's just fresh off her gig with Operation Transformation. So we're delighted to have her here this evening. Sumi, thank you so much for your time. Really appreciate it.
Oh, no, Sinead, thank you very much.
Oh, you're more than welcome. And
Delighted.
Sumi,
Delighted. Yeah.
Oh, super. Thank you. Sumi is one of our keynote speakers at the 2024 National Menopause Summit, which I believe everybody in Ireland is now aware is a 2-day symposium at the Aviva Stadium on the 11th and 12th of April. And we have worked with Sumi at our inaugural summit in Dublin and again at the National Menopause Summit in Cork. So she's one of our team, and we're delighted and thrilled to welcoming her back to the Aviva this year. So, Sumi, this evening it would be wonderful to have kind of a general chat with you just in terms of menopause care from a GP perspective and why people should go to their general practitioner when they're experiencing menopause and how your GP can help in that regard.
Completely. I think, I think the first step really for everyone to realize is that general practice is open and we've become much more facilitative and understanding around perimenopause and menopause care. And as it's happening, within Ireland, most practices now will have somebody who is invested and interested in menopause and perimenopause care. So the days of heading into a GP and saying that's somebody that's not as keen in women's health, or they may not be as up to speed in menopause care, that's actually diminishing, which is great because the message of education is getting out there. Certainly our younger trainees that are coming into general practice are having a really good grounding from a lot of us involved in education around menopause care. And as you are well aware, one of your fabulous speakers, Dr. Brian Kennedy and Deirdre Lundy, have established a Telegram group where over 1,000 GPs are invested in education and improving quality evidence-based menopause care. So we're growing in numbers. It may be a case that you might have to ask pointedly who is interested within the practice in menopause care, and it may not necessarily be the female doctor in the practice. Our male partners are pretty good nowadays at all things menopause and perimenopause because they have partners, they have sisters, they have aunts, they have mothers, they will have daughters coming into the era. So it's not in isolation. That silo of saying, oh, I've got to find a female doctor interested, that might not be the case anymore. So do ask in your practice. And if there's anyone within the area that you have a chance of seeing, I understand it's a little bit more difficult if you have a medical card because that tends to anchor you to one doctor, but it's worth asking around.
Yes.
Say, is there anyone locally that you can signpost me to if this isn't your area of expertise? So that's also, very doable as well. But the first port of call I would say is that do knock on the door. We are here and we are accessible. And what's even better is that if it's our patient group, we know you.
Yes, of course.
We've come on a journey with you. So we will have your past medical history. We will know your allergies. We will know your suitability. We will know if there's any contraindications to medication or not. And if you choose after lots of information not to take HRT, we'll support you on a non-HRT journey as well.
Fantastic.
And Sinead, what I'm finding nowadays is that broadly speaking in general practice, I've got 3 groups of women. I've got women who are really invested, have done their reading, and they'll come into me and they'll say, I really want to talk HRT. This is what I'm going through. I've done my green score. Here's one for everyone in the audience. It's highlighted on your, your web pages. They've done their green score. They're aware of their symptoms. They're coming in and they want to talk HRT. Fantastic. Then I have another group of women who are very pertinent to Deirdre and Quiver and Brian, and they fall into our complex group where they need complex advice, and that may be medically mitigating symptoms that need a little bit more wraparound around that. And broadly speaking, that's our sex hormone cancers, our active liver disease, immunosuppression, or someone that's had a history of clots. That's broadly speaking. So they tend to get moved out of general practice. Okay, so that's our second group. And then our third group, equally important, are women who have done all their reading. They know their symptoms, but they choose not to take HRT.
Yes.
And equally, so we need to respect all three groups. And now there's an emergent group coming through of those that want to know more and more and more. We need to be able to give time and space to be able to give really good information back to these women so that they can make a choice to be in a group that either can take HRT, may not be suitable for HRT, or may not choose to take HRT.
Yes. Yeah.
And that's how I see the role of general practice: information giving, information gathering, a robust examination, signposting to things that may also be relevant, because parallel journeys can happen in health.
Yes.
You know, because we're on a perimenopause or a menopause journey, there may be other medical conditions running in tandem or parallel that have equal importance. So we dilute from either. Around that. So I think that's where the role of general practice is that if you've got somebody that knows you and that has an overview, you're not having to repeat information twice.
Yes, good point. A good point. Yeah.
You're not having to go in to say, oh, by the way, I've got this, this, and this. And do you know, 20 years ago, this was an issue. Family, this was an issue. Is that going to be a problem? We've got that. And then we can carry on with that. And if we know, for example, previously, if taking hormones in an earlier part of your reproductive journey by taking the pill, that didn't suit you, then we can also work around that, because some people are hormone sensitive and they may just go, the thought of hormones again, which is the mainstay of HRT, it's hormone replacement therapy.
Yes.
That may not suit them. So again, it's having all that information at our fingertips that makes us a great ally to women in general practice.
Yeah, no, it's fantastic. And it's a really good point, as you say, Sumi, that, your GP has been working with you for years as your clinician and has that history. And you're not going to have to go in and tell your life story, which is going to take quite a bit of time.
No,
exactly.
And absolutely. And, and there are other things, that are so important. People feel sometimes, or they get put off, they think, oh, I might get a pelvic exam or a breast exam. That's not necessarily the case. If you came into me and you said, I'm worried about my breasts, and it happens to be an HRT consult, I will undertake a breast exam.
Yes.
If you're the appropriate age for screening for women in the Republic of Ireland, mammography begins at the age of 50, and you haven't, it gives me an opportunity to signpost you and tell you how to sign up for that. Similarly, whilst you're in with me, we check to make sure that your cervical screening is up to date.
Exactly. So important.
If there's a parallel journey of diabetes, we make sure that you've signed up for diabetic retinopathy screening.
Yes.
There's so much more there than just sitting with HRT on its own, because everything is equally important.
Yes.
It's not just having that one aspect in isolation. And I think that's where it makes general practice quite unique around kind of overall care for our patients.
No, that's really helpful, Sumi, and they are really, really good points. Just in terms of having a sort of a 360 on the person that you're dealing with, if it is a patient that you have been dealing with for some time. And I just wanted to make reference to the famous green score. So I will say this, I will say this with no problem at all. Putting together the National Menopause Summits has been an absolute education for me. Obviously working with the likes of Sumi and Deirdre and Brian and Kiva, and even on the workplace side with all the people we work with in that regard. So it was you, Sumi, actually on one of our, I think it was one of our group speaker Zooms when we were getting our ducks in a row in line, in time, should I say, for the, I think it was the Cork Summit actually, that you mentioned the green score, which I personally, because I'm not a clinical person, I was like, oh my God, what is that? So do you want to give everybody a little bit more detail on that?
The green score was a score, would you believe, devised back in the 1970s. And it was devised by a psychologist with an interest in women's health. And at the time, kind of perimenopause and menopause were deemed climacteric, in a very elegant term to say there was issues with your own internal climate. You know,
Right.
there was a change. You
And
know,
not an unfair sort of
no, no, you know, there's a change. There's a change in climate. You know,
Absolutely.
do we take that metaphorically? Do we take that literally? Do we take that globally? But there was a change. So, and this psychologist, Dr. Green, actually came up with 21 plus, depending again regionally, there's regional variations of common symptoms. And some of them are what we call physiological, as in there are absolute body changes and we can make sense of them. And some of them less physiological. They could be mood affect, or they could be just very, very internal and unique to the person. For example, you know, some people may describe tingling in their fingers or jaw pain. That isn't commonly cited in the literature, but we hear that, you know, as well. Anxiety, you know, there's, you know, how do you explain anxiety? But yet some very, very capable women undertaking this journey will say that was actually my most crippling symptom, anxiety and loss of memory. You know, and yes, now we've got more physiological understanding as to the loss of memory aspect with our decreasing hormones. But back then it was all kind of like, how do we put all this together? So the score was devised. And it's got arbitrarily about 20 to 21 symptoms. The ones that we're really interested in as doctors, absolute ones, because we know we can do something about it, is the hot flushes and night sweats. And they come down somewhere on the list. And that's because that is pure physiology. And, you know, we talk about this at the summit, but what happens is that the thermostat in your brain, as your estrogen levels go down, it goes haywire. So it doesn't know what's happening to it. And that regulation of temperature tends to go. So instead of keeping us at steady state, it suddenly goes, hold on a minute, I actually do think that you're in the Arctic. So what I'm going to do is make you really, really hot and sweat and sweat and sweat for no reason, because outside cues might be okay, but that internal thermostat isn't working. So by replacing estrogen, it re-regulates and it resets that thermostat. And with resetting the thermostat, the night sweats go and the hot flushes go. So there's absolute biology around that. And that's why it's that fixation on hot flushes and night sweats. But that's not to say other aspects come into play as well. So in a way, when we start the HRT journey, that's what we're looking for in terms of dose response. So if someone's in and they start HRT, what we're listening to say is, if I started you on HRT, has it improved? And we may get a whole load of improvement in symptoms, but we're really listening out to say, what's the thermostat like? So if the thermostat is reset and we're not sweating at night and we're not having hot flushes, that improves sleep.
Yes, of course.
You know, as one of the things. We also know one of the components of HRT, if taken as a tablet, the progesterone aspect, again, physiologically induces sleep. Okay, so we know if we give you progesterone as a tablet, it will make you sleepy. And one of the things we commonly hear is that my sleep is horrific. I used to be a really good sleeper, and now I can't sleep at all.
I can relate.
So, you know, so we, you know, give you a hormone to regulate your thermostat, and then we can give you a hormone to make you sleep. And the impact of the two of them, I'm not sweating at night and I'm getting sleep, then means I can function. And if I can function, then I'm not feeling as wrecked and I'm back on my A game. And is an absolute winner. So along that journey, a lot of women also find by giving these hormones and what we call titrating, and titrating is responding to an individual, because what works for you, Sinead, won't work for me, won't work for my next door neighbor, won't work for all of my patients. We've got to remember this is all really individual. That when we titrate, and we will typically see patients back every 6 weeks to 3 months in order to make sure that everything is, you know, coming on board nicely. There are no side effects. There are no red flags, and I'll talk about that in a minute. And that the dose response is appropriate. Do we need to tweak? Either way. And then when we hit the lowest dose of hormones, if that's the journey people choose, that is the most appropriate, and there's no night sweats, and there's no hot flushes, and we're getting some sleep, we're on a winner at that point.
Fantastic. Yeah.
And there are other things that come along the way. So many things can be tweaked that may not address, for example, sex life, not address libido. And as I say to a lot of my patients, HRT is fantastic, but it's not smart. It's not going to go, hey, I'm going to travel around and hit every receptor on the body. It just doesn't do that.
Yeah, absolutely.
And particularly the cells in the vagina. HRT isn't going to travel as the gel, as the patch, or even as the tablet in your mouth and go and hit the tissues in the vagina. And the tissues in the vagina, as we get older, get depleted of estrogen, and they get thinner and they get more susceptible to trauma. Trauma even from wiping, trauma from sex, trauma from friction. So, and that can set up that vicious cycle of a lot of older women experiencing urinary tract infections, when in fact it's very local, it's vaginal estrogen that's needed. So that's a strand. So here we've got hormones to either rub on or put a patch on, a hormone to take in your mouth, and now we're thinking of vaginal estrogen. Because if sex doesn't hurt, and it doesn't hurt to pee, that's another winner,
A big win, absolutely.
Big win,
Absolutely.
And that also helps with lubrication, and that in women might be part, coming back to helping with the libido. One of those strands right in the green score that we noted, what's my sex life like? Horrific, not so horrific, getting there, getting better, but I do warn you, if you don't like your partner to begin with, no amount of vaginal estrogen.
Indeed, no doctor can help you there, ladies. I'm sorry.
We've got a little bit of pragmatism needs to come into play at that point.
Exactly.
So there's lots there. So what, I jump from one to the other. What the score does, the score gives you as a woman to see where you are. And it may make sense that when you go down all of these symptoms, as I said, there's 21 plus, some of them might apply to you, not everyone. And some of them may be, oh my God, this makes sense. All of this kind of uncertainty.
Yes.
It's kind of, is it my heart? Is it my brain? Is it my joints? Am I going mad? Do I need a blood test for everything? It may actually put all that jigsaw puzzle together. And that's what Dr. Green wanted. They wanted to put together the pieces of the jigsaw.
Yes.
Then signpost women further.
Yes.
And then, history comes, and medical history, like all history, has to be subject to change. And the first elements of HRT, when it was realized that this was linked to a depleting journey, was, well, let's throw hormones back at women. And it wasn't done in the most elegant of fashions.
Right.
And that's where some of the scare studies back that we hear about became associated with, the very first form of HRT was formulated from pregnant horse urine with the name of pregnant mare urine. But we've got much more refined, we've got more refined in our approach. So medical history changes, pharmacology changes. So this is where general practice has moved. The score has stayed the same.
Yes.
Years.
Yes. And I suppose sorry to cut in on you there, Sumi, what's really useful about the score, or you can download it as a menopause checker online, or it's on nationalmenopausesummit.com website if you want to download it from a sort of a patient perspective. It means that you can take a little bit of time to do an audit on your own symptoms before going into your doctor, in which case you can get to the point of the matter in a bit more of an efficient fashion. And certainly being someone myself during my menopause journey who really struggled with brain fog, if I'd gone into the doctor, I would have forgotten half of the stuff that was ailing me. So at least I can go in and know what it is in particular according to the score that I'm suffering from. And I assume, Sumi, from a clinician's perspective, that's going to be a much more efficient use of time. I'm in with you.
Absolutely.
Yes.
You've done all the work. If you come into me with a green score, the work is done.
Yes.
And a glance with any of us that have interest in menopause care will actually start signposting us along the way as to how to optimize your care. And then it will come down to us taking a medical history and making sure, if you choose HRT, and that's the way that you wish the next part of your journey to evolve, then it's suitable for you.
Yes, yes,
And,
that,
and we can really concentrate on that bit
yes,
around that.
yeah,
So that's where having this score in hand is so invaluable to you.
absolutely, yeah.
And it also, and really interesting, only last week, there was a woman that came in with the score and handed it to me. And it was immediately apparent that what was happening to her was nothing related to perimenopause and menopause
Wow, okay,
at
interesting.
all. So there's that other corollary. So that's why the overview needs to come from a clinician.
Yes, absolutely, of course.
And and part of her information gathering, unfortunately, hadn't come from the most robust of sources, but she'd done a green score, which was phenomenal.
Mm,
We were able to check lots of things, but her underlying issue was not perimenopausal or menopausal, which
that's
is
really interesting, yeah.
which is equally important. So there's so much to be gained by doing that body of work yourself,
Mm,
particularly as people are finding it's difficult enough to get into general practice. And
yes,
then it's also, really to give credit and to do absolute due justice to a perimenopause, menopause consultation. The first consultation can be quite long.
yeah.
And general practice may not have that time.
Absolutely. Absolutely. No doubt at all. Yeah.
And if you're coming in with a score, then the rest of it, really coming down to the nitty gritty, are you medically suitable? Do you wish to consider hormone replacement therapy, or would you prefer a journey without hormones and revisit it again or never again? That makes that bit of navigation easier for us.
Yes. Yeah, no, absolutely. And another thing as well, Sumi, that I know we all discussed before and was certainly something that came up on the summit, is in terms of advocating for yourself. So I'm going to use an example here, okay? A personal example. So when I was originally prescribed HRT, which was a journey I was always going to go on, and thankfully I'm one of those people who doesn't suffer from a complex case, so I was able to do that. And now, in fairness, this was during COVID. Okay, so I was prescribed a particular delivery method for HRT, and many months later, it was giving me bring me back to a point where I was maybe 60% as good as I had been previous to actually going through my perimenopause and menopause journey. And I kind of sat at home going, well, it's not really working, but sure, we'll give it more time to kick in here. And what that kind of taught me then, when I actually went back to the doctor and eventually sort of woke up and went, it's not working to the degree that I would like it to, is to make the point to people that it's really important as well to advocate for yourself. Now, I know obviously you have a check-in with your patients after a certain period of time, but again, as a female on HRT, if it's not feeling as good, and I know you're going to discuss red flags now in a moment, as potentially it should, it's really important to check in with your clinician in that regard. Is it not, Sumi?
No, absolutely. I mean, and again, those of us that are, prescribing and interested in menopause care, is that the first consultation, we tend to see you back at about 6 weeks to 3 months.
Yes. Okay.
And the reason for that is that you do need that length of time. Coming to me a week later or 2 weeks later saying it isn't working, that hasn't actually given what we call the medication a chance to work. So you really need to sit it out for 6 weeks, if not 3 months.
Yes.
And then, an evaluation, a real clinical evaluation at the end of 6 weeks, 3 months, possibly with tweaking, possibly with different delivery mechanisms. So, for example, at the moment, we've got gels for estrogen, we've got sprays for estrogen, and we've got patches for estrogen. And there's, different brands, there's different manufacturers, there's availability, but they pretty much get the estrogen into you through your skin. And somebody might not like a gel. They might actually not tell you that extra 5 minutes in the morning after the shower is 5 minutes too long.
Indeed. Yeah.
And they might, and they may be too scared to ask. And do tell your doctor, if a gel's not working for you, let your doctor know, because we can change you to a patch. And similarly, some people with patches find that they fall off.
Indeed. Well, I was, again, just using myself as the guinea pig here, the
Yeah.
HRT example. I was on the patches for quite a while, and they were working wonderfully for me. However, very strangely, because I've never had any allergies or skin allergies or whatever, I developed a bit of an allergy to the patch, and I would wake up in the morning where I had, in my sleep, scratched myself to the point that the patch was falling off. So again, exactly, I gave that a bit of time. I didn't call the doctor the first day that happened, but I realized over the period of about a fortnight that something has gone wrong with my skin and the patches. It's just not reacting. So I moved on to the gel. So, you know, the journey in terms of delivery methods for HRT can be a little bit touch and go, and it certainly was for me.
You know, it can be touch and go. And, you know, and the other thing that we need to bear in mind is that one delivery mechanism might actually suit you better than another. So,
Indeed. Yeah.
you know, I've had patients, and all of us have had patients that have come in to say, this isn't working, this dose isn't working. And interestingly, rather than going to a higher dose, changing the delivery mechanism might be what actually gets you enough of the estrogen back into you. So someone may not be absorbing through a gel, but they might absorb through a patch. They might not absorb through a patch, but they might absorb through a spray. And you might even find that as doctors, we rotate you. So rather than necessarily going up and up and up a dose, higher the dose, the more potential for side effects. I would go back to, you know, an absolute gold standard of prescribing. The lowest dose that suits you is the best dose.
Yeah.
And that's because, you know, some people might say, I'm on these really high doses. And there was a lot of things in the media about, you know, women aren't being prescribed high enough doses. That should have actually read, women are being prescribed appropriate doses. And doses that work for women are fine, not high doses. The lowest dose that works for you is the best dose for you. You know, and we can't say that enough.
Yes.
And so rubbing on the gel may not absorb for you. So you might be able to get it through a patch. You know, if the patch is hanging off because you've scratched it off, or there's an S bubble, or you know, some common body oils. If you know you've moisturized vigorously and you try to put a patch on, it's going to fall off, I'm afraid.
Of course. Yeah, absolutely.
Fake tan is no friend of a patch, you know.
And that's a real problem for me.
That's not a journey I've had to go down, but you know, word to the wise, it's not so much the tanning element, it's the oil-based element that you know, causes the adhesive to come away. So there are elements like that, as you've said, you know, local skin reactions. That might not suit. Some people may not like, you know, where they have to put a patch because you know, clothing, if you're going on the beach, you might not want to show that you're wearing a patch.
And I will just mention this, Sumi, because I think anyone who has ever worn a hormone patch knows what a bugger it is to try and remove that black thing around it.
Oh, it's and you know, and then you know the little peel off bits of plastic. They fly, and it's like static. They stick to everywhere except going in the bin. You know, and then you've peeled off one bit and you've stuck a bit on, and then there's an air bubble, and then the phone rings and you've got the other bit hanging off you. You know, so you know, real life comes into play with these things.
It does, absolutely.
You know, but there is a bit where now, you know, I wear my patch with pride. So when I was on holiday through the summer, I didn't give a hoot. It was stuck on my thigh, and it was kind of, you know, if I saw another woman with a patch, we kind of like,
they were like, there you go, hello.
You know, it's sort of like sister solidarity kind of thing. But you know, but I am cognizant that some patients choose to wear their patch in an area which isn't as exposing, and that's fine as well. You know, our only rule of thumb for a patch is to wear it below the belly button. That's the if there's a little bit more leeway with where you can apply a gel, and the spray is applied in the forearm here. And again, you know, manufacturing availability, and you know, supply and demand. And you'll find this is the other beauty in general practice, is that when we send you out with a script, we will actually be able to write on the script, if there is no gel available and there was a shortage in the summer, please prescribe this dose this way instead. And if this brand of a patch is not available, then please prescribe this brand, which is exactly the same. Or if, for example, you know, the most common dose prescribed is 50 micrograms of estradiol. If that's not available, well, then 225 patches are fine.
Perfect.
So
Yeah.
and again, general practice is able to do that, and we can stipulate that on your script. Coming back to answer why come into my GP,
Yes. Yeah. No, fantastic.
And with every consult, when I talk about red flags, the questions that we ask at review are, have you felt any breast lumps? There will be initial breast tingling and tenderness. You've got to remember some women will still have their own cycle going on in the background until they're fully menopausal. So, you've got your added estrogen from HRT, and then you might have your own cycle coming into play. So there could be breast tenderness, but if it's persisting for a long, long period of time with discomfort, and certainly if there's any lumps, we need to know about that. So those that are invested in HRT and HRT review will ask that question. We will ask you, about pelvic bleeding, vaginal bleeding, whether you're on what we call a continuous regime, where, you are taking hormones all the time, or a cyclical regime, where you are having one regime for 2 weeks, and then you don't take progesterone for 2 weeks. And in that 2 weeks, you have a bleed, and then you go back for that. Is there any what we call breakthrough bleeding? And what to do if there is breakthrough bleeding? Is there any issues around sexual intercourse? Is that causing bleeding? Can we, if we haven't considered vaginal estrogen, is that something that needs to come into play? And I come back to vaginal estrogen all the time because I think we have been woefully underrepresented, and our older female cohort never got the benefit of vaginal estrogen. And the best way to describe it, it's almost like sun cream and lip balm.
Yes.
We don't think about it nowadays. We put on the sun cream and we put on the lip balm. Why? Because we know it's protective. We want that. And it's the same. Vaginal estrogen is protective.
Yes.
To, thicken and lubricate the vaginal tissues.
Yes.
You're not going to get that soreness from trauma, urinary infections, as I've said before, intercourse. So that's a consideration around that. But if there is breakthrough bleeding or persistent bleeding after intercourse, then we need to know about that.
Of course. Yeah, absolutely.
If we give you hormones of any description and you get a persistent headache, a migraine with aura, that's something that we need to know about. We will check your blood pressure on every HRT review, because if spuriously your blood pressure starts going up and you've always had normal blood pressure, we need to look into that. So that's kind of, quite simplistically, almost in a reductionist manner, some of the review checks and balances. But it's really important, again, for women to know this is what our, GPs are interested in.
Yes.
Why they're asking me these questions. They sound really personal, but that's the importance of answering them. And I'm always fascinated by the response, when I say, well, what are the sweats like? Or what are the night flushes like? And I get, they're a little bit better. Little bit isn't good enough.
Exactly.
Little bit doesn't sit for
no,
me.
little bit. I agree with you, Sumi. And again, sorry to cut in you there. During my HRT journey, when I was at that 60% going, I really had myself convinced that if I got up to 70%, I would be winning effectively. And I have come to subsequently realize now that I am on a protocol that works so well for me that I am every bit as good as I was before menopause or perimenopause ever kicked in. And I cannot, encourage people strongly enough to shoot for the stars here, to go back to consider how you were before perimenopause and menopause as the gold standard to getting your HRT correct.
Absolutely. And, and again, with HRT, certain formulations don't suit certain women.
Exactly.
So this is where, we're talking here about poor sleep. I've said progesterone as an oral tablet will help your sleep, but some women don't like that. It makes them bloated. It may make the breasts more tender.
Yeah.
In which case we can direct you to taking it in a different fashion, or we may say, a Mirena coil is the best, way of getting the progesterone with minimal side effects. But then we also have to respect women that say, I don't want a coil.
Yeah.
There are so many avenues to work with around this. And again, individual cases, and in general practice, what we can tell you is that if you have a womb present, it's not been removed surgically, then you need estrogen and progesterone. It's not negotiable.
Yes, yes, absolutely.
And then, even more so, are you bleeding or are you not bleeding? Because there's one regime if you are still having periods or scanty periods, and there's another regime if you've been bleed free for a year. So, and that can help shape for a lot of women where they're going to go next.
So quite a lot of elements involved in making that decision, very individual experiences and individual histories tailored in a bespoke fashion, if you like, Sumi.
Absolutely. And if you don't have a womb, then you don't need the progesterone component. But we need to know that, and we need to be asking that. And, and if anything, if you've been my patient, or any of our patients over the years, we may know your background history. So
exactly. This is the advantage of going to your GP, of course, as you were saying at the top of this chat.
And with this, and I guess it's my other interest that comes into play, and and I've said this at all the summits that we've had together, no amount of HRT, whether you can take it or not, or it's not suitable for you, is going to mitigate against lifestyle. You still need to carry a journey of lifestyle. So, for your bone health and your cardiovascular health, which we know HRT improves outcomes, but really the optimization comes from, moving well and eating well as well, and certainly, bone dense type exercises. So those that increase our muscle mass, so doing weights, and I will, probably be the hill that I expire on. We can walk and walk and walk, but that's not going to build.
Exactly. And this is the kind of stuff, unfortunately, Sumi, that a lot of people don't want to hear, because, do some weight bearing exercise, increase your general movement, up your game in terms of the quality of your nutrition. And it's understandable. A lot of people are like, oh God, no, but it is so incredibly important.
It's incredibly important. And particularly for our women that choose not to take HRT and our women that cannot take HRT, this becomes the mainstay of minding them through their perimenopause, menopausal journey.
Yes.
And we have alternative medications for the flushes.
Yes.
But we won't have anything as effective as HRT to look after your bones. Won't have anything as effective as HRT to look after your heart, except lifestyle.
Yes, absolutely.
So, and that's to respect any woman that's listening to this today who may be saying, but I actually can't take HRT, or I don't want to take HRT, but I'm really interested in looking after my bones, and I'm really interested in looking after my heart. And that's absolutely understandable, and we need to recognize that. So no amount of HRT is going to take away from the fact that we still, have to do these things really.
And look after ourselves at a very basic level, basically. Yeah, no, absolutely.
And my other hill that I'm going to die on, and I will say this again, and I will say it loudly and proudly in the Aviva, no amount of oat milk is going to get you the amount of daily calcium you need.
Absolutely. Couldn't agree more. Yeah.
So we need to be looking at our diet to make sure, well, what are our calcium sources like? What are our vitamin D sources? We live in Ireland, we're not going to get sunlight. I'm really sorry. I'd love to prescribe sunlight regularly.
You would have a very long queue in front of your practice if you were prescribing sunlight, Sumi.
Absolutely. So we don't get that. So how are we going to incorporate that into our diet? And dairy, if tolerated, and there are very few people with a true lactose intolerance. And if so, medically diagnosed, absolutely, we recognize that. If you are not taking dairy because you don't like the taste of it, or you may say, oh, I might get a bit bloated, that may not be a true lactose intolerance.
Well, absolutely. And do you know what, Sumi, this is a whole separate conversation, but I personally have a problem with the fact that it's called almond milk, oat milk. It should be called almond juice, oak juice. It is not milk. Stop it now. And it is not a substitution for milk. But anyway, that's a whole other conversation.
A whole other conversation. But I think, the core message here will be, dairy is our friend.
Absolutely. Yeah.
Women through their journey in order to look after bone health, and again, in moderation, because you don't want too much saturated fats because we look after our heart. So everything comes to a moderation effect. And
Yes.
you know, that's where that respect in the journey comes for all women, because we're all going to have depleting estrogen. We're all going to go through a cyclical change. You know, how we come through that is really individual.
Yes.
And yet, you know, we want to advocate for women that wish to take HRT, but we want to advocate for women that can't or choose not to take.
Absolutely. Yeah, indeed. Yeah. No, that's fantastic. And before we wrap up, Sumi, would you mind just very briefly touching on the thorny subject of testosterone?
Yeah, no, absolutely. I think lots of press, lots of media. You know, you open up, you know, any kind of, you know, paper, magazine, internet, it's the new female Viagra. You know, testosterone will sort it all out. There's lots of emergent evidence around it. And yes, you don't need to go to the highest doses of estrogen before you start testosterone. There was a body of thought to say, let's optimize HRT, progesterone, and estrogen, and then look at starting testosterone. It's very much individual again, and it's very much again in consultation with your GP. It is not the magic wand. I cannot say that enough. And what we do find is that testosterone is actually licensed and only licensed currently for low libido in women. So despite starting on HRT, despite some vaginal estrogen, things are still not, you know, optimized with getting libido going. And libido in women is really complex, Sinead. It's not binary like our male counterparts.
Yes,
you know,
indeed, yeah.
You know, it's very, very different. But there could be a really strong component for, you know, arguing why testosterone works. And that, again, there is physiology behind it, because we do have endogenous testosterone as women. And
Yes.
that comes back to, as we get older and we start losing our hormones, we start losing testosterone as well. And that's how we start losing muscle mass. You know, to draw in the strand of lifestyle, we need to keep our muscle mass. But our depleting testosterone will also have an effect on our muscle mass. But it may not in everyone have an effect on libido. It may in some, it may not in others. And what we do know is that if we are going to start prescribing testosterone, we are listening, you know, and we are saying, well, you know, is libido because of environment? Is libido because it's endogenous, as in you've tried everything and it's not working? Is libido something that's really important to you, or it's not as important to you? So again, really individual. And when it comes to testosterone prescribing, there's no reason why, you know, we can't give it a trial.
Yes.
We will do bloods first. We will check for your own intrinsic, what we call total testosterone levels first, because if they are coming up to the upper end of normal, then a tiny bit of testosterone might just push you into a range that is what we call too high. Okay.
Right.
So we check that first, and we just see what that is like. And it just gives us an idea. And most women won't be in the higher normal range. They'll either be in the middle or they'll be in kind of the lower end because they've started their perimenopause, menopause journey. And some women, as I've said, even with a low level of testosterone, may not find it affects their libido at all. And other women, even with a slight drop, it's really had a massive effect. Then we will start you on a trial of testosterone gel, and again give you explicit instructions on how to apply, where to apply, and how often. And if anything, you know, less is more. You know, if we were given you a sachet of it, it's not open it and just rub it all over, because again, there's a chance of overabsorption, and we don't want that.
Of course.
So you'll be directed again on the formulation type and how it's dispensed to you, on, you know, how to take it. Typically, after starting testosterone, 6 weeks later, we'll do your blood levels again.
Okay, yeah.
To make sure you're not hitting that upper high range of total testosterone.
Yes.
And if you're not, then we'll let it go at that amount that you are rubbing onto yourself for 6 months.
Yes.
Do another set of bloods at 6 months. So it's pre-testosterone bloods, 6 weeks after starting it, and then 6 months.
Fantastic.
And then at the end of 6 months, really critically, the hard question will be asked, has this made a change?
Mm, mm.
If it hasn't, then we stop it, because if it's not going to work within 6 months, then it will never work.
Yeah. That makes absolute
Yeah.
sense.
And the numbers overall are really, it's surprising. Here we are saying, wow, it's amazing, blah, 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 blah. It will do so much. The popular press will have you saying, it's not being prescribed enough. But on the ground, when you talk to women, we kind of find not as many as you think actually get a good result with it. But it's worth persevering if that's the route you wish to choose.
Yeah.
It's worth persevering for 6 months. But if after 6 months it hasn't worked, no amount of robbing on testosterone is going to change that.
I think that's fair enough, and I think most people would accept that.
Mm.
One of the very positive piece of data that we captured, just in terms of this conversation, we did a menopause survey. We had over 850 people respond to it, was that a large proportion, which is really good news, of those people now believe that HRT is safe, which is super. So thankfully the old message is dissipating, and the facts are getting through, which is super. But having said that, as you say, Sumi, and I agree, how people wish to manage their perimenopause and menopause journey is absolutely, we must respect everybody's decisions in terms of how they would like to manage that, and that's only right.
No, absolutely. I mean, and what we do know, coming from the UK, and Deirdre will talk more at length at that, is that there are new non-hormone mediated drugs coming specifically for our women that have undergone a active breast cancer journey, for whom currently, the medications that we have to manage hot flushes really are not optimizing their care. So that's exciting, groundbreaking news.
Really exciting. And just to, if I may, Sumi, just mention at this point, if anybody's interested in more details on that, if they jump onto the chat I had with Dr. Deirdre Lundy, which is live here on our YouTube channel, Deirdre goes into some detail on that. So that's all terrific news. I think, Sumi, thank you so much. I'm going to wrap it up at this point. That's so much information and really helpful. And certainly for me, chatting with you this evening, I think one of the most pertinent points is the fact that your GP has a 360 understanding of your general health, has presumably been treating you for many years. So there's huge advantage to going to your GP in terms of treatment of your menopause. And as you say as well, Sumi, your GP is interested in that. Your GP wants to chat with you about that, but do give it maybe a shout beforehand to make sure that there's somebody within the practice that can deal with that. And do not forget about filling in your green score.
Absolutely.
Before you go to take
your green score.
Exactly. If I may say, to take the pain out of trying to remember, if you're suffering from a number of symptoms, what those symptoms were, because we can all be a little bit flustered and under a bit of pressure when we go to the doctor. So do bear that in mind. So Sumi, once again, thank you so much for joining me this evening. That was super helpful. And just to let everybody know again, of course, that the National Menopause Summit does take place on the 11th and 12th of April at the Aviva Stadium this year. We are rolling out the same content across both days, so people can pick whichever date works best for their calendar. And obviously tickets are available on the event site, which is nationalmenopausesummit.com. So we will see you again here on our YouTube channel. Please be sure to subscribe and share it with anybody that you think would be interested in this information. And I'll finish up once again, Sumi, by saying thank you so much for your time this evening. Really appreciate it, and really looking forward to working with you again at the Aviva this year.
Thank you very much, Sinead. It's been a pleasure.
Okay, thanks, Sumi.